friends, colleagues, faculty, to start with the first introduction session chaired by Dr. Padma Shri Gulati and Dr. Girish Verma. You know, Dr. Girish Verma is a retired professor in HOD from Kota, and Dr. Padma Shri Gulati is from Jhansi. So I would request the chairperson, Dr. Girish Verma and Dr. Padma Shri Gulati, to start the first session on introduction. Over to Dr. Padma Shri Gulati and Dr. Girish Verma. Thank you.
Thank you, sir.
Thank you. Thank you. So at the outset, I, Dr. Padma Shri Gulati, along with my co-chair, Dr. Girish Verma, would like to thank Dr. Manoria sir and Dr. Mahapatra for making us a part of this scintillating International Heart Failure Summit too. So we are going to start with a topic on heart failure, a 360-degree panoramic view by Professor P.C. Manoria sir, who is a legendary orator and is the director of Manoria Heart and Critical Care Hospital, Bhopal. He is a former professor and head department of cardiology, Gandhi Medical College, Bhopal. He has been the past national president and past dean of various medical organizations and has been awarded with numerous prestigious awards nationally and internationally. He has organized several national and international conferences and has more than 74 publications to his credit. He has delivered more than 800 lectures in various conferences. So without any further ado, I would request Professor Manoria to take the stage. Dr. Manoria, sir, please.
So good morning, everybody. For the next 15 minutes, I'll be talking on heart failure, a 360-degree panoramic view. The last couple of years has witnessed spectacular advances in the field of heart failure, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options. The first big message is that the four foundational drugs for heart failure, that is beta blockers, SGLT2 inhibitors, ARNI and MRAs, all with class 1A recommendation, have kicked off a drug revolution in heart failure which was never existing before, and this is powered to improve the survival of patients of heart failure. And all these four drugs should be utilized in treatment of heart failure, and they are now considered as GDMT for heart failure. The beauty of all these four drugs is they provide incremental benefit on top of each other, and therefore they should be utilized. So if you ask me what is the single big message or the big dicta for treatment of heart failure, it is door to GDMT time. You have heard door to balloon time or door to device time in myocardial infarction. This is the new most important dicta in heart failure, which means when a patient is admitted with heart failure or you are treating on an OPD basis, try to initiate GDMT with all four drugs at the earliest. It may be on the first day itself. And once it is initiated, the next dicta, door to maximum dose GDMT time, try to reach the target doses within a short time, preferably before discharge, but not more than 2 or 3 or 4 weeks. And this is important because 1 out of 4 patients hospitalized for heart failure die or is rehospitalized within 30 days of discharge. And 30-day mortality in ADHF is to the tune of 10%. And here you can see the new sequencing in the treatment of heart failure. Right from day 1, if possible and feasible, you should initiate all these 4 drugs in lower doses and gradually escalate them to their target doses. And if you do so, you can see you achieve a panoply of benefits, as you can see on the screen. And here you can see if you are on a guideline directed medical therapy in the yellow or the suboptimal medical therapy, there is significant change in the mortality. And if you look at the projected survival in a 55-year-old male, you can increase the longevity by 6.3 years. And if you look at the event-free survival. If you initiate all these drugs at the age of 55 years, the event-free survival is increased to the tune of 8.3 years, and if you initiate at 6.65 years, it is increased to the tune of 6.3 years. The second big message is that after the positive emperor and the preserved and the delivered trials, SGLT2 inhibitors can now be utilized across the spectrum of heart failure, irrespective of ejection fraction, and this is a big feather in the cap of SGLT2 inhibitors. And SGLT2 inhibitors, as you can see, the recommendation in HFpEF, which Dr. Mahapatra was talking, is now endorsed by the ACC guideline 202 2ABR recommendation, and MRAs are also endorsed at 2BBR and ARNI, same recommendation. The third big message is that HFpEF no longer remains an orphan disease after the positive emperor, preserved and the delivered trial. The other big message is there is excellent reverse remodeling by the 4 foundational drugs which had forced the committee members of the Universal Definition of Heart Failure 2021 to create a new subset of improved ejection fraction which never existed before, and this is again a big feather in the cap of the 4 foundational drugs. Other big message is exciting data has emerged from the PROVE-HF trial. It has transformed ICD eligible patient into ICD ineligible patient. I'll be showing you the data, and all of us know ICD is a very costly device. And still on top of all these, the drug revolution for heart failure with reduced ejection fraction is poised to postpone device therapy, which means it will postpone ICD, CRT, LVAD, and even cardiac transplantation. So much strong is the drug revolution in heart failure at the present state of time. Now, all of us know heart failure, once sets in, runs a malignant progression with a very high morbidity and mortality. The 5-year mortality is to the tune of 50%. Drug therapy, device therapy blunts this malignant progression and in no doubt improves survival, but does not arrest it. This is because the human myocyte is not endowed with an endogenous capacity for repair. Once dead, is dead forever. And therefore, cell therapy has emerged as a very exciting action. But after several years of research, we still do not know is the end of the beginning or beginning of the end. And therefore, prevention of heart failure has emerged as a big agenda in heart failure. And rightly so, ACC has also endorsed it. Stage A heart failure is now redesignated as at risk of heart failure, and stage B as pre-heart failure, so that you can use various measures to prevent heart failure. The treatment of heart failure basically revolves around drugs, devices, and transplant, but I will be only talking about drugs for chronic heart failure, as devices and transplant are being covered by other speakers. Now, this is the ESCHF guideline 2021, and I think all of us are familiar with it, so I will skip over. Now, when we look at the evolution of treatment of heart failure prior to SGLT2 inhibitors, all drugs which have improved outcome modulated their action through neurohormonal modulation. You can see beta blockers, AC inhibitors, MRAs. They target the maladaptive neurohormonal modulation, and sacubitril valsartan increased the activity of vasculoprotective natriuretic peptides or the natriuretic peptide system. Now, 2019 initiated dawn of a new era when DAPA-HF trial was presented and was positive and improved outcome, and DAPA laid the first foundation stone for HFrEF. And this kicked off a new era of SGLT2 inhibitors in heart failure, emperor preserved. We have similar results in 2020. And now from chronic heart failure, we have trials in acute heart failure, impulse trial, which again is positive, and other trials are ongoing. Besides this, we have 2 other pathways, the soluble guanate cyclase pathways and the myosin activator pathway, which I'll be talking to you. So at the present state of time, we have multiple pathways for heart failure, and treatment of heart failure has undergone a revolutionary change. When we look at sacubitril valsartan, these are the landmark trials all of us are familiar with, and these are the landmark trials which paved the approval of sacubitril valsartan in chronic heart failure and acute heart failure. And this is PROVE-HF trial. As you can see, excellent reverse remodeling by this trial. And this is the data which I was talking, 613 patients, ejection fraction less than 35, all were eligible for ICD. And at the end of 1 year, you can see as much as 61% patients increased their ejection fraction to more than 35, and they become ineligible for ICD. And the ejection fraction undergoes a dramatic change with this therapy. So the new message for ARNI is optimize use of ARNI before ICD implantation for primary prevention of sudden cardiac. SGLT2 inhibitors, they are a panacea for heart failure and a boon for CKD. If you look at the meta-analysis for hospitalization for heart failure, across the board, SGLT2 inhibitors decrease hospitalization for heart failure, whether it's HFrEF, HFpEF, high-risk patient with ASCD or without ASCD, ADHF or CKD, and the benefit is achieved very early, as you can see, and decreasing hospitalization for heart failure indeed is a big achievement in the treatment of heart failure, because every hospitalization, every rehospitalization takes the patient closer to death. This is the Emperor Preserve trial. All of us are aware of this, and it showed a 21% reduction in the primary endpoint of cardiovascular death hospitalization for heart failure, driven by decreased hospitalization for heart failure. Cardiovascular death and all-cause mortality was not affected, and renal benefit was not seen, unlike the reduced trial. All subsets benefited less than 40, less than 70 years, more than 70 years, male, female, all subset of ejection fraction and all other subsets. And we have now the DELIVER trial, which has been reported to be positive and will be presented in near future. DAPA-HF trial, all of us are familiar with it. It showed improved outcome, the primary endpoint, cardiovascular death, hospitalization for heart failure, and urgent HF visit were decreased by 21% with benefit in all-cause mortality and the cardiovascular mortality. And interestingly, DAPA-HF also showed reduction in ventricular arrhythmia, as you can see in this slide. Both DAPA-HF and Emperor showed reduction in hospitalization for heart failure, but DAPA-HF has reduction in all-cause mortality and cardiovascular mortality. And we have the dual SGLT1 T2 inhibitor, the sotagliflozin, which has improved the primary outcome in the pooled analysis by 28%. Same benefit was seen in HFrEF and HFpEF. And sotagliflozin in the SCORE trial showed very interesting data of reduction in non-fatal MI and non-fatal stroke, which has never seen with the SGLT2 inhibitor. We have the IMPULSE trial in ADHF after hemodynamic stabilization, as you can see. So now you can use these agents in ADHF after hemodynamic stabilization. They also improve the quality of life. The mechanisms of SGLT2 inhibitors are multiple, as you can see. I'm not going to discuss. They also decrease interstitial edema, which is one of the important reasons why they show positive results in HFpEF, and they can be used across the cardiorenal continuum. We have the soluble guanylate cyclase pathway, and this is targeted by verisuget, which directly stimulates the soluble guanylate cyclase pathway and improves and increases the production of cGMP, which provides protection for the blood vessels and the myocyte. And this was tested in the Victoria trial, which has come out to be positive. And you can see a 10% reduction in the primary endpoint of cardiovascular death of first hospitalization, driven by decrease in hospitalization for heart failure and not by cardiovascular death. And the drug has been given a 2BB recommendation for worsening heart failure. It's once daily medication, easy to titrate, and usually well tolerated. Monitoring of renal function electrolytes is not required. We have the omecamtiv mecarbil, which activates the myosin activator, and it was tested in the Galactic HF trial, and as you can see, 8% reduction in the primary endpoint of cardiovascular death and HF event, driven by decrease in the HF event. And one must never forget iron deficiency, which is rampant in heart failure, and we have data from several trials. It should be corrected, and this should be regarded as the fifth pillar for heart failure. Vaccination in heart failure is also mandatory, and you can see the data on the influenza vaccination decreasing CV mortality, the data on the pneumococcal vaccination. So in summary, the 4 foundational drugs for heart failure should be utilized for all patients, as they provide incremental benefit on top of each other, and the door to maximum GDMT should be achieved at the earliest, preferably before discharge. The physician inertia should be minimized and patient motivated for long-term polypharmacy to improve survival. The 4 foundational drugs are poised to postpone device therapy and even cardiac transplantation. Never forget, heart failure once sets in runs a malignant progression, and all therapies should be escalated in target doses unless side effects preclude their escalation, and one should not try to attempt de-escalation because heart failure is never stable and is potentially dangerous. HFpEF no longer remains an orphan disease. The emperor preserved and the delivered trials are positive, and these agents will be used in the treatment of HFpEF. In heart failure, the cardiorenal continuum should be targeted and never heart failure alone. Targeting CKD triggers benefit for heart failure. And vericiguat is a new weapon approved for heart failure with reduced ejection fraction after ARNI and SGLT2. And omecamtiv mecarbil is still not yet approved, undergoing evaluation. IV iron must be utilized because this is very common deficiency in heart failure, and pneumococcal influenza vaccine should be given. And prevention of heart failure emerge as a very important agenda, because heart failure once sets in runs a malignant progression, and the human myocytes are not endorsed with endogenous capacity for repair. Once dead is dead forever. Thank you very much for your kind attention.
Thank you very much, sir, for an excellent talk and addressing all 4 pillars for congestive heart failure, and not only addressing the newer things, but also telling us that what is the role of vaccination, which is a new perspective or new thing in the treatment of heart failure. Sir, you have shown us various trials of dapagliflozin and empagliflozin. So I would like to ask you, how will we select between dapagliflozin and empagliflozin for treatment of heart failures?
That is an interesting question. The guidelines do not differentiate between DAPA and EMPA for treatment of heart failure. But there are certain differences. If you look at the DAPA-HF and the EMPA reduced, DAPA decreased all-cause mortality by 17% and cardiovascular mortality by 17%, which was not shown by the EMPA reduced trial. The reduction in new onset diabetes was also more, with DAPA 32% versus 8%. So there are minor differences, but this is not a head-to-head comparison. So the guidelines do not differentiate. You can use DAPA or EMPA in patients with reduced ejection fraction, and now also with preserved ejection fraction.
So there is one more question that we know that acute decompensated heart failure patients, when present with us, 30% of them have the abnormal renal function. So there is interplay between this heart and renal abnormalities. So how do we see, and what precautions we should take while treating the patient who is presenting with cardiorenal syndrome, or what is the continuum of cardiorenal syndromes?
While treating heart failure, we must never forget to target cardiorenal continuum. If you treat heart failure alone without bothering about for the kidney component, the benefit will not be maximized. Never forget, treating CKD triggers benefit for heart failure. And interestingly, SGLT2 inhibitors target both the component of cardiorenal continuum. They decrease hospitalization for heart failure and also mortality. And they slow down the trajectory of CKD and postpone dialysis by 10 to 15 years, which is indeed a very great achievement. So both the components should be targeted rightly.
Thank you, sir.
Can I ask a question, sir? So if a patient of heart failure improves with the drug therapy that's been given at the outset, so do we de-escalate the dose of the drug once the patient has improved?
Never forget, heart failure is always an unstable condition. Never try to de-escalate therapy. Always escalate unless side effects preclude their incrementation in the dose. The only two exceptions are peripartum cardiomyopathy and Takashobu cardiomyopathy, where you may attempt to de-escalate, but that de-escalation should only be given not merely on the basis of reduction in ejection fraction. The GLS has also to be shown to become normal. Then only you may attempt, but you have to be. But otherwise, we never recommend de-escalation, because heart failure only goes into remission, it is not cured. So always maintain the therapy. There are these two exceptions where you may think, but the TED-HF trial showed that if you de-escalate, many patients do not show the improvement which they were showing before de-escalation. So always try to maintain, except under certain circumstances.
I'd just like to make a small comment, I think, because we have seen a lot of patients of COVID cardiomyopathy, and most of them, they improve completely. That's why there is a radical reversal of cardiomyopathy under remodeling. And number two, septic cardiomyopathy. A lot of patients of septicemia, they also have a complete reversal of the remodeling. So these are the two additions, but we need more data. And I think a lot of data is coming up in cardiomyopathy. In my own experience, I've got 9 patients of COVID cardiomyopathy, completely reversed. And we have to de-escalate, and they're doing well. I'm going to stop them because they're inflammatory. So inflammatory pathology easily reversed as compared to non-inflammatory. These two, we need more data. But I think Dr. Manoria has given a very beautiful outlook that two entities, especially increased epinephrine, norepinephrine liberation, reversal is 100%, as well as in peripartum. But these two have to be added in the due course of time.
Thank you, sir. Any more questions from the?
I think, if there is no question, Dr. Padma, I think we will close this session. And thank you very much, Chairpersons Dr. Padma Sri Gulati and Professor Dr. Girish Verma, to spend your valuable time here. And also the Dr. P.C. Manoria, our senior eminent speakers. So thank you very much. Now we go into the second session, is a clinical session. Before I invite the chairpersons, I would like to just a little bit in sequence change, because Dr. C.K. Pandey has another meeting. So he has spoken to Dr. Darshan Jhala. So instead of Dr. Darshan Jhala being the first speaker, chairpersons are requested to call Dr. Pandey as first, then Darshan Jhala, then Dr. Jamshed Dalal.